my experience, most patients who phone out of hours concerning back pain is because they have had a flare-up or a recurrence of a previous episode. Acute back pain obviously needs to be managed slightly more cautiously, and a higher need to exclude the risk of aortic aneurysms and spinal cord compression. And I always ask about a history of previous cancer and spinal surgery. Clearly, there is a need to explore the possibility of saddle anesthesia or bladder dysfunction. I normally start this discussion, particularly with women, by apologising that I need to ask some private and embarrassing questions, because I need to make sure that they are not at risk of having problems with their bladder and continence. I explain that the saddle area is usually what we would call the area sitting on a bike saddle, and would cover from around your vagina vulva back to your back passage, or in men from the scrotum to the back passage. I ask if they've had any numbness or noticed any change in sensation when they've been wiping themselves. I ask if they've been having any trouble with their foot, particularly if they've noticed they've been tripping over it. I have not had anyone say yes to that question. I also ask if, with their legs straight, if they can curl their toes up to their face. I believe that excludes the most likely severe acute foot drops. I find the majority of patients phoning with back pain have already tried simple analgesia, paracetamol, with or without an anti-inflammatory, if tolerated. I therefore personally often find myself prescribing up the pain ladder, and will often use cocodamol 3500s, advising the patient to never take more than 8 tablets per day, and to slowly substitute each tablet for a normal plain paracetamol, keeping to a maximum of 8 tablets per day. I will occasionally add in Oromorph with or without diazepam on a 3 or 5 day course to reduce muscle spasm if I believe that muscle spasm is significant. For the Oromorph, I will always advise a test dose of 2.5 mils on the first dose, repeating within an hour if tolerated, but the pain remains severe, and then continue on 2.5 to 5 mils 4 hourly, documenting each dose in case further dose adjustment is required.